The literature will tell you there's about a 30% miss rate with blinded injections. Blind injections are a thing of the past. I don't know how many people I've talked to and they say, oh no, I just palpate and I do it. That's just really not safe. It's not accurate in that. So it's really a thing of the past. We need to be accurate with what we are doing. These are very important, expensive procedures, and we need to provide our patients with the highest quality of care. I am Dr. Casey Charlebois. I'm going to be talking about musculoskeletal diagnostic ultrasound, a turnkey addition to your practice. I am by medical trade a physical therapist. I have what's called the alphabet soup because I didn't spend enough money in PT school. So I did an orthopedic manual physical therapy fellowship, and I also got my PhD, and then I'm certified in diagnostic ultrasounds. The most powerful thing that ultrasound does is that it gives you real-time imaging right there at the point of care with the patient. So it's a little bit better than an X-ray, and it's a lot better than an MRI. It's more powerful than MRI because I can do dynamic testing right away. You're not going to do that in the MRI tube, right? You can't even breathe. I had an MRI on my neck, and they said, you're moving. I said, I'm just doing deep breathing. They're like, stop. I'm like, okay, but it's this tube, and I'm kind of stressed out. But with ultrasound, we want the patients to move. We want to stress that tissue because we're looking at that tissue physiologically right now. Not an hour, not tomorrow, not in a week. It's right now what is going on with those patients' anatomy. Also, we kind of say what's normal, right? So we have the involved side where the injury is, and then we have the normal side. Well, with ultrasound, I can move that probe back and forth, and I can decide, is this normal for this patient? When we talk about diagnostic ultrasound, it gives us clarity and confidence in what we're doing with the patient. So I don't know about you guys, but in PT, I do special tests all the time to try to rule in and rule out, is this a bicep tendon? Could this be a rotator cuff pathology? Is this impingement? And unfortunately, the sensitivity and specificity of those manual tests and those special tests doesn't hold water. They're somewhere maybe like 50 to 70%. It's really not that great. And we palpate the patients like it hurts here. All right, well, already I'm thinking 4 or 5 different structures, including even the spine, right? Because it could be radiating there. But now with my ultrasound probe, I can put it on there and I can get some more objective information. Is this matching up with the patient's symptoms in history? Is this matching up with some of the special tests that I'm doing, some of the palpation that I'm doing, right? Am I able to recreate that kind of pain pattern as to why they walked in the office to see me? So with the ultrasound, I can look at a bunch of different things and I can get some instant answers with that. Okay, if we look at the knee, so the knee and shoulder are the 2 biggest joints. I have a love-hate relationship with them. There's a lot of structures in a small space, right? And the knee just really like flex and extend. Sure, there's some tibial rotation on that, but really it's just a 2-joint motion, but there's like 18 structures in there. So if we look at this, we can look at patellar tendinosis. So we can differentiate, is it proximal in jumper's knee or is it distal in Osgood-Schlatter's, right? So we can tell that with ultrasound. An LCL tear, an MCL tear, medial meniscus, lateral meniscus, we can assess all those things. Baker's cyst, I had one of these last year. I like to try to jog like around spring and my knee blew up and I said, jogging career is over, no marathons for me. The elbow, is it tennis elbow? Is it golfer's elbow, right? Well, what I love about the elbow in ultrasound is that I can differentiate. Is this a common extensor tendon problem, or is there something going on in my radiocollateral ligament just underneath it? Or maybe a little bit of both, right? So with ultrasound, I'm able to differentiate and determine that. And then plantar fasciitis, so that morning pain you get up in those first few steps. But what's great too is we can also assess the tarsal tunnel on the medial side of the ankle. If there is compression in, say, the nerve that's along there, or I've got some peroneal tendonitis, those things can mimic plantar fasciitis. So with ultrasound, your differential diagnosis is like on point. So ultrasound can pick up fractures, tendon tears, nerve compression, DVTs, everything. I think you're kind of getting the grasp of that. If a patient says it hurts here and they lay on their side, what are they usually diagnosed with? Bursitis! Okay, well finally people are starting to like come around and say it's not bursitis. Do we know what it is? Anyway, gluteal tendinopathy. Glute med or glute med tendinopathy across the board. It's like the glute med and glute med are like the rotator cuff for the shoulder, right? It really, really is. And sorry, us ladies that are refined, that have gone through menopause, we're at a higher risk of it. So what used to be greater trochanteric pain syndrome is really gluteal tendinopathy. Because true greater trochanteric pain syndrome is down here in the glute max bursa. Now, there are bursa between and sandwiched between the glute min and the glute med. I'm not saying that at all, but true greater trochanteric bursitis is actually subglute max. Your lateral hip patients, scan that glute min and glute med tendon on there. We have seen 126% increase in our orthobiologic procedures. The only thing that has changed is that people have a tangible report that they can take home. It's laying on their kitchen table. Oh, my rotary cup, yeah. I can't quite reach on the shelf and get that glass anymore. What did she say I could do? Or what's that report say, right? So it really does help kind of solidify those of you that are doing the injections. It helps that sale a lot. Expand your services. So most of you raised your hands. I don't know what capacity you're using ultrasound in right now, but we're going to talk about how to increase the capacity of your diagnostic, which means increase revenue. Because your patients are coming to you and they're going back and they're telling their friends, oh my gosh, I went to Dr. So-and-so and I had my shoulder scanned and they gave me this report and I have a tear and I'm getting it help. And they're like, what? I want to do that because what? People want to avoid surgery, right? And they should be avoiding surgery. And then also stand out in your competitive market. So you do something different than the provider down the road. You have upped your standard of care. You have upped your patient outcomes and proficiency. The equipment used to be expensive, right? So we used to have these cart bases that were like $50,000 in that. But now we have handheld devices that are wireless, that work on your phone or your iPad that are about $5K. So it's more portable, it's more manageable. It really is becoming the standard of care. A lot of you raised your hands, you're already understanding that, right? We talked about the safety and the accuracy of it and giving patients power day one when they walk in for an evaluation. You can put that probe on there and you can scan them right away and talk to them and educate them. Because I guarantee you other providers have used so much fear with them in regards to, oh, it's bone on bone. That's the worst knee I've ever seen, right? We are just really not doing our patients a good service with that type of language. Well, now we have tangible information that we can provide to them. Here's what we're seeing. Here's what we can do about it, all right? The longer you wait, the more your clinic falls behind and the more the patient falls behind too, right? Weeks for an MRI, even just to get in and then to get the results. They're going back and forth between providers. They probably had 3 or 4 appointments by then, right? Instead of coming to you and you've got it all in-house. Imaging delay hurts outcomes. Again, we could start treatment on that patient sooner if we know what's going on with them at that point of care. They don't have to wait more weeks in order to get a prognosis and diagnosis. Patients want things faster. We are in a tech world right now. It's like at a flick, a reel, whatever, right? Patients want the information now. We don't want them going to ChatGPT and typing in and saying, I can't reach in the cupboard, it hurts when I lay on that shoulder, what do I have, right? Or Dr. Google. No, we are still the people that need to educate them and let them know what is going on and what their plan of care is going to entail.